You're listening to the Good Question Podcast with Richard Jacobs. Our goal is to make each of our guests exclaim, that's a good question. I don't know the answer. Because when that happens, it means you, the listener, may be inspired to learn more beyond the interview and to ask great questions yourself that lead to new insights. In this podcast, we cover historical and current anthropology, comparative religion, and history. Welcome, and let's get started.
Hello, this is Richard Jacobs with the Good Question Podcast. My guest today is Kelly Anderson, Ph.D. She's a group practice owner at Wellness Therapy of San Diego. And we're going to talk about schizophrenia and people that have psychotic episodes. So welcome, Kelly. Thanks for coming.
Thank you so much for having me.
Yeah, if you would, just tell me a bit about your background, how you get into this area of work, and then we'll go into what you do today at the clinic.
Absolutely, yeah. So I've focused on serious mental illness, SMI, throughout my training. Throughout grad school, I worked in hospital settings, working with folks inpatient, and carried that into my internship and postdoc. And my postdoc, which was a joint program between UCSD, University of California, San Diego, and the VA that we have here in San Diego. And I had a specialized postdoc in working with folks with psychosis and schizophrenia specifically. So it was a program that did treatment as well as research, program improvement, things like that to serve the needs of folks with schizophrenia and psychosis here in San Diego. So I've been long experienced in this area.
Well, why this area? Why is it a fascination for you? Are there people you know that have this issue personally? Like, why this area, not others?
Yeah, that's a really great question. So I've always been really kind of interested in folks who are on the more severe end of symptomology. So we hear a lot about folks with anxiety and depression, and I think that gets a lot of news and media attention. And it became clear very quickly in graduate school that folks who were having more serious issues, people who fell under the serious mental illness umbrella, had a lot less access to treatment, research, things like that. Funding is more scarce for people like that. And so it just seemed like there was a need to kind of do more treatment here. And as I carried my career forward, it became very clear that there were very few practitioners who practiced outpatient therapy for people who have serious mental illness. So there was this huge need, yes, here in San Diego, but also nationally, for folks who aren't in need of hospitalization or intensive care, but are maybe too impaired for your average private practice. And so bringing in my expertise and being able to help folks who are kind of in this middle area get the best treatment they can became a passion of mine very early on.
Okay. So what kind of conditions cause people to have a psychotic episode? And what is a psychotic episode? What does that mean?
Yeah, that's great. Really, two great questions. So psychotic episode can mean a lot of things. I think most of us out there confuse schizophrenia and psychosis as being one and the same. And they're actually two different things. Schizophrenia is just one type of psychotic episode or psychotic spectrum disorder that someone could be diagnosed with. So when we look at psychosis kind of holistically, we're looking at a number of things. So we're looking at kind of the most common symptoms that people talk about, which would be hallucinations or delusions. And so with hallucinations, we can see those show up as visual, seeing things that aren't there, auditory, hearing things, tactile, feeling things, and then delusions, believing things that aren't kind of tied to reality. So oftentimes in movies or media, we're going to see this as someone who believes they're being pursued and believe that they're being watched or chased, and that would be a delusion. There's also a whole host of other symptoms that don't get as much attention, but are just as problematic for folks. Some of those are behavioral. So we'll see people who are very disorganized in their behavior. What they're doing doesn't match on with what we would expect. So we might see someone in the middle of a San Diego summer wearing winter clothes and a parka, even though it's very, very hot, or people who can't quite organize their behavior, so their movements look a little bit different or atypical. There's also a lot of cognitive symptoms. So we see a lot of confusion. We see a lot of word finding difficulty, thought stopping, which is someone's in the middle of saying something and they can't finish the sentence, lack of concentration, things like that. And then we see a whole host of other symptoms like depression and anxiety, paranoia. So when we think about diagnosing or looking at psychosis, we're looking at symptoms that fall into a few different categories beyond just what we call positive symptoms, which are things like hallucinations and delusions, but also mood changes, cognition changes, and then what we call negative symptoms, which are people having trouble getting out of bed, trouble socializing, feeling very sad or down, those sorts of things. So we see that kind of in a few different categories and look across those to come up with a diagnosis and one that would be specific to what that person is experiencing, whether that's schizophrenia or a different psychotic spectrum disorder.
Well, why would they experience some symptoms versus others? What, are there certain triggers? Why does this happen in some and not others?
Yeah, that's a wonderful question. So a lot of this is highly genetic. So we see that people who have a predisposed genetic disposition to schizophrenia are more likely to develop schizophrenia. And then it's a matter of what in their environment might have triggered that. Was it trauma, abuse, those sorts of things? And then another time we see a very high incidence of psychosis or schizophrenia is substance use. So psychedelics of any type, including marijuana, can be one of the biggest ways to trigger a first episode. But generally, when we see folks who are coming in and they don't have a substance abuse history, there's usually an underlying genetic component that got triggered. And as far as the symptoms that one person might experience versus another, it's sort of like someone who just experiences depression. One person might have increased appetite when they're quite depressed, while another person might have decreased appetite. One person might be able to show up to work most days of the week. Another person might not be able to get out of bed. So we kind of look for clusters of symptoms across all diagnoses, and schizophrenia and psychosis aren't different there. And so when we're looking at, is this person meeting that diagnostic criteria for psychosis or schizophrenia, we look for a number of different symptoms in a few categories to get there, just like we would for depression, anxiety, trauma, those sorts of things.
If something is genetic, how could it be triggered by a life event?
Yeah.
Because of epigenetic change that now exposes a gene that's transcribed, or what's the reason?
Yeah, so the theory when we're looking specifically at schizophrenia, which is one of the most researched and studied psychotic spectrum disorders, is what we call the stress vulnerability hypothesis. So the vulnerability is that genetic predisposition. We're born with it and we just had that gene. I tell clients who are struggling with wondering why they were an unlucky person to develop psychosis, that it'd be the same as people who have the gene for breast cancer. It stinks, but we can't change it. It's there. But just because we have a gene doesn't mean we're going to get it. So there are lots of folks who have some of the genes for various types of cancers, but it never gets triggered. And that's where the stress component in the stress vulnerability hypothesis comes in. So we look at stress, and that can be physiological stress. I had a major illness. COVID was one more recently where we saw this kind of push a whole bunch of people into the psychosis realm because of how much stress COVID placed on someone's body who had that vulnerability. But it could be physiological in terms of stress with an illness. I've had veterans who had 48, 72-hour shifts where they didn't sleep and they never returned to baseline, and their psychosis started then. So that kind of physiological stress. It could be stress like it sounds like to most of us. So I've had a very stressful day, week, month, year, prolonged stressors in my life that I just can't cope with, and that triggers the vulnerability. Or again, things like abuse, trauma, neglect. And then of course, if you do have a genetic vulnerability, if you're using any substances, you're increasing the likelihood of developing psychosis just significantly.
What about SSRIs or other drugs for depression or other conditions? Do they ever lead to psychosis? Well, you're talking about just, marijuana, MDMA, stuff like that.
So there's a chance that they could. It's rare, but SSRIs do increase serotonin, which is one of the primary neurochemicals that we look at in psychosis. So that is possible. I don't think it's high up on the list because it would require a lot of that, or probably someone who's had it. And there are lots and lots of folks who will take an SSRI even if they have psychotic spectrum disorder who don't experience any sort of difficulty there. So it could happen just like anything else. I've had someone who had a steroid and then had a psychotic episode. Incredibly rare, the only one I've heard of in my career, but possible. So absolutely that could trigger a vulnerability as well.
Is anyone looking into the microbiome of people that have schizophrenia? or, other alternative ideas about it?
I don't have a lot of knowledge on that, but I would be shocked if there weren't, as we're learning more and more about gut health and all of those sorts of things and its relationship to other mental health conditions. And that's really kind of clear link. I wouldn't be surprised that there isn't emerging research there, just not an area that I'm super educated in.
What about diet? Is there any dietary recommendation to avoid or have or change to help this condition?
None that I've ever seen. The biggest sort of pieces with diet are post-diagnosis. And the reason for that is many antipsychotics that people are described create a metabolic syndrome that leads to weight gain, diabetes symptoms, a lot of like metabolic slowing, and that just is really hard on the body that's already struggling. So there's a lot of research at looking at healthy habits for brain health with psychosis. And again, that would mirror stuff that we would see for anxiety, depression, trauma. If you have a healthy body, you're certainly going to improve the chances of having a healthy mind, or letting medication or therapy kind of help make the improvements that your brain would hope for.
So what are some of the treatments that you'll, put forth at your clinic? What are some examples?
Yeah, that's a really great question. So the primary line of defense for folks with schizophrenia or psychosis is going to be medication. That's still kind of a front line. And that's often a first recommendation, our first desire for clients. And so in our practice, we do have a nurse practitioner who can prescribe medication, that sort of thing. So that's something that's possible there. But many folks are coming in already on medication when they're coming to our practice for treatment. They're oftentimes looking for psychotherapy and have been hospitalized once, twice, a half a dozen times, have been through med trials and are looking at ways to improve their life from another direction. I use two primary approaches with folks with psychotic spectrum disorders. Number one is cognitive behavioral therapy for psychosis. And the other that I really, really enjoy using and has a lot of efficacy is acceptance and commitment therapy for psychosis. And so there's a lot of overlap between these two therapies, but really it's looking at how do I come to terms with my symptoms? How do I challenge positive symptoms like hallucinations, delusions? What do I do when those happen? How do I get more social? How do I get out there when I feel like I'm being persecuted or if I'm having some paranoia? So we do a lot of cognitive restructuring. We do a lot of emotional processing. We do a lot of acceptance around what life looks like with a psychotic spectrum disorder, and what that might look like if we have some symptoms that are not well managed through therapy and medication. But there are also a number of other psychotherapies out there as well that are just as great. And a huge component of overall treatment for folks with particularly schizophrenia is group treatment. So there's social skills training, which helps folks who are having some negative symptoms. So therefore, they're having like a lack of desire or skill with socialization. They can join groups to help get that. There's behavioral family therapy where everyone comes in the family system and they get therapy together to help support, yes, the person with the diagnosis, but also the changes that promotes for families. So we can kind of look at things on an individual level, a group level, or even a family level based on each individual's needs.
Well, how do you help someone if they're having a strong episode, they're having delusions, maybe false memories, things like that? How do they get through to themselves? How do people get through to them?
Yeah. And the very shortest answer is sometimes you don't. And then there might be a need for a higher level of care. So something like hospitalization or inpatient treatment, where a family member or even the state could kind of require treatment, which usually looks like starting with medication and then kind of working from there. But if folks are on an outpatient basis, even if they're having hallucinations or delusions, oftentimes either they themselves are identifying that there's a problem or a trusted family member is identifying a problem and they're willing to come and talk about it. And then it's a very, very slow process. So if someone isn't quite sure what's real or what isn't, my job isn't to try to convince them of reality or disreality. In fact, that's the fastest way to get someone not to trust me is for me to say, that's not real, that's a hallucination. And so we work together to build insight, which looks at, if there's someone else in this room talking to us, how come I don't see them? Or, you said that you heard someone, in the walls of your home last night, but your parents said that they didn't hear such noises. What was going on there? Or so on and so forth. So we help the client kind of make sense of what they're experiencing and what other people in their reality are experiencing, and then discover that disconnect. And again, that's a very, very slow process of building trust and understanding of the client from the therapist perspective and getting that client to trust you so that they can go to this really scary place of challenging what they believe is reality.
Well, again, how does someone handle it when they're having an intense episode? What kind of preparation can be done? How does it work?
Yeah. So, oftentimes we do see kind of signs or symptoms if someone's moving into a psychotic episode. Before a first episode, we do have a phase that's called the prodromal stage, which most people see in retrospect as, oh gosh, the signs were there. We just didn't know what they were. We didn't know why this person seemed to be acting this way. So if someone can recognize those signs, there might be a early intervention, which is one of the number one things that that lead toward successful outcomes. Is the earlier we intervene and get treatments in place, the better outcome folks have. But most folks miss that window because it's so insidious and such a slow onset, unless it's substance induced, that it slowly kind of slips in this dysreality, the hallucinations, delusions, paranoia, especially the negative symptoms. So the feeling withdrawn, the isolation, things like that. They're hard to catch until we start getting some of those kind of bigger symptoms. But if someone has had a couple of psychotic episodes, they tend to have an idea of what to look for in terms of what their early symptoms are, their red flags are. If they don't know, that's part of what a therapist can help them identify to create sort of a proactive plan. So if they start to move into relapse, we can catch that a little bit earlier. And so it might look like I'm feeling less of an ability to socialize. My thoughts are getting more disorganized. I'm thinking I'm hearing things. And the moment we catch those signs, we go to therapy. We talk to our psychiatrist and see if a med change is in order. If folks have done things like TMS or electroconvulsive therapy, ECT, they might go back for a booster session. But if we miss that window and things get really severe and a person isn't able to make contact with reality, that's typically when they'll go inpatient for their safety. And they'll be treated with medication, almost always brought back down, sometimes even down to baseline, where then the psychotherapy or other kind of behavioral interventions can take place to try to get more skills on board to keep that person from relapsing again.
I don't know, like, do people just take a while to be able to learn how to get the skills to help themselves? Do they get better pretty quickly? And, it seems like a lot of people that have schizophrenia will stop taking medication and relapse. Why?
Yeah, you're exactly right. Timeline oftentimes for folks with psychosis looks a little longer than someone with maybe a less serious mental illness or concern like depression or life changes. But that being said, I have folks with depression or anxiety who have had years and years of treatment, and it's still really tough for them. And so it can be tough. And part of that is based on severity. Part of that is how well do meds work to get us kind of down to baseline. Part of that is motivation. And that's true for anyone, regardless of what they're coming into therapy for. But you're right. A huge issue is medication compliance. And this is true for folks with psychosis as well as a number of other physiological and mental health conditions. And so someone will feel like they're doing really, really well, and they'll go off their meds, and then they'll kind of they'll decompensate and have another psychotic episode. And oftentimes they won't get that care until they're at a very, very kind of significant place. And we see this often with depression, anxiety, things like that, where people have symptom relapse with those conditions as well. The other big thing here is oftentimes with psychosis, there's a lot of paranoia and a lot of mistrust. And so if I start to have psychotic symptoms seep back in and I stop trusting the people around me, I'm going to withdraw. I'm going to stop taking my medication because I don't trust the person who prescribed them. My clients will stop coming to see me because they worry that I'm not on their side any longer. And so they withdraw from treatment. They withdraw from care. They'll withdraw from their families. This is a time that becomes really critical for homelessness and things like that, because people get scared and leave. And then they
well, why does this happen? How do you stop it?
Yeah. Well, I don't know that there's any stopping it, right? You can use all of the interventions, and many folks get a lot better and live a life where you wouldn't know. It's there's something like maybe 3 to 5 people in 100 who suffer from a psychotic spectrum disorder. So every 100 people you meet, there are a few who have these symptoms going on who are either managing them well or well enough that you don't notice. this is the same for folks who have any other kind of mental health illness. We don't know who's out there suffering and kind of why. And for some folks, the medication works. For some, it doesn't. Just like, again, I use the cancer treatment. For some people, they'll get chemo and they'll go into remission and never have another round of or relapse of that cancer. And other people, they just don't respond to it. So there are genetic components, there are environmental components. And again, a big piece is early intervention, just like we would see with diabetes, heart disease, things like that. So a lot of it comes down to sort of the genetic material we have, our ability to stay committed. Social support is a huge piece in schizophrenia and psychosis. So if someone is kind of slipping into this or decompensating, that they get that support and someone who they trust on board to help them get back into care as quickly as possible or step up that care. But the whys of it aren't 100% known outside of those things that we've talked about in terms of going off meds, substances, falling out of treatment, a new stressor coming up. Those are all things that we can kind of understand happening, but are sometimes hard to predict or prevent.
So no one knows why this happens and no one knows what to do about it, or like what's the state of things?
Yeah, I don't think you mean like people don't understand how psychosis begins to start with, or why people relapse.
Yeah, why people fall out, why people relapse, and how to get them back after that's happened to them.
Yeah, no, I think it's, if we know the individual and what's going on with him, I think that's pretty clear as to what could be going on most of the time. So certainly I have a subset of clients who are doing the therapy work, they're on their meds, they might even be on an injectable medication, so there's no risk of missing a medication dose or stop taking it. They don't have an identifiable stressor and something happens in their brain where they have a neurochemical dysregulation and they move into a psychotic episode. So that does happen. But for other folks, we can sometimes go back and backtrack and look at what happened. Was it missed medication doses? Was that intentional or unintentional? Was it that I took the wrong medication dose because I got confused? Was it that things were going well and then I had a grief issue come up, someone I love passed, or I got fired from a job, or I got physical illness? So is it a stressor, right? We can usually go back and piece those together, but it's hard to predict those things in advance. And only the individual who's kind of coping with those things knows what they're feeling. And if they start to back away from the people around them, their treatment team, their family, it can be hard. And by the time they've recognized that there's a serious issue, they're often kind of in that psychotic episode and not in the kind of building up phases of that coming back.
Well, can you teach families how to recognize, problems in the person themselves to head this off before it gets to be really bad?
I love that question because yes, absolutely. Family members, which is why behavioral family therapy is such a important component of psychosis treatment. So family members can learn what those early signs look like and hopefully intervene or encourage their loved one to step up care or change their care before the symptoms get so severe that that person completely disconnects from family or treatment team.
Are there people that can be cured, or is it just like the longer they go without having a psychotic episode or falling out, the better? Are they considered to be cured ever?
That's a tough question, and I bet you would find people in various camps, but my camp would be no. Once you've experienced a psychotic episode, you are always going to be making sure that you are doing everything you can to prevent another one. We do know that the more psychotic episodes that a person has, the poorer outcome. And typically for most people, each additional psychotic episode is a little bit more intense, a little bit harder to recover from. They might have kind of lingering symptoms for longer. So again, that early intervention, as young as possible, if we think that this is happening, and as quickly as possible between episodes is important. So I have folks who certainly get to a place where they're doing so well that they choose to go off of medication, and some will even go off of medication and still feel good enough to end therapy. And they may go the rest of their life without another psychotic episode. That's not the case for most people. Most people are going to stay on meds as a lifelong stabilization process because, again, we're looking at a highly genetic, highly neurological, neurochemical mismatch in their brain that their brain can't always correct for. But I have so many clients who get to a place that they're living a highly valued life, and that's often a combination of medication and therapy, as well as going out and pursuing what they want in life. So jobs, friends, marriages, I have tons of folks that I've worked with who have families, children who go on to not have psychosis, those sorts of things. So you can still live a full and valuable life, but it does take time and consideration and attention to make sure that you're not falling into relapse.
Okay, well, very good. What should people look for in, people they care about or they know or themselves to raise the suspicion, maybe I better go see someone to be evaluated?
Absolutely. So one thing to keep in mind is that there is research would show that there are critical periods. For boys/men, we see this earlier, and they're going to have their first psychotic episode, again, when we're leaving substance-induced psychotic episodes as a disclaimer out to the side. Most of those are going to happen earlier, and so between 20 and 25. And so we start to see some of this show up in late adolescence, which is tough because it's not unusual for a high school student, a 17, 18-year-old kiddo to withdraw, to have social issues, to deal with changes and appear a little bit depressed. But those would be some signs in young men or, young adults that are going on. If we start to notice that we're withdrawing socially, if we start to notice that we are having trouble thinking, things aren't making sense, I can't distinguish my thoughts, or I'm thinking all the time, but none of these thoughts make sense. And certainly if you see, hear, smell, taste, touch something that no one else around you is seeing, hearing, responding to. So those would be some big red flags. For women, we tend to see first episode of psychosis a little bit later. So they're looking more at mid to late 20s for first episode. Again, being very careful not to confuse this with substance-induced psychosis, because that changes the whole lay of things for men and women. And so we would see some of these symptoms showing up. And of course, for young women in their 20s, these are going to be kind of noticeable because we wouldn't expect social changes or kind of angsty adolescent changes happening in our mid to late 20s. So they might be caught a little bit earlier. But the kicker here is that women often go longer without a diagnosis than men. Men are more quickly diagnosed with schizophrenia or psychosis than women, but the same symptoms would show up there. Are we having disorganization in our thoughts, behavior? Are people noticing things and they're letting us know, hey, something's not right here? Are we feeling a change in the way we think about ourselves in the world? That would be a really good time. And then, of course, if you've had a previous psychotic episode, whether you are the person who experienced that episode or a family member, we'd look for any and all of this. But the number one thing I would tell people to look for is just a change in mood. That tends to be the first thing we see. And it tends to show up as kind of really intense anxiety and or a big shift in depression. So those are the things that I tend to kind of see as a yellow or maybe even red flag in my own clients when we've been working together and their mood changes significantly. I start to say, okay, we've got to really keep an eye on any emerging psychotic symptoms. If you're not sure, find an expert in your area and go meet with them. Go and see if there's someone that you could have either yourself or a loved one talk to about what's going on to see if they think this could be an emerging psychotic disorder. Here in San Diego, we have a lot of resources. In other smaller areas or smaller town cities, it might be a little bit harder, but telehealth has made that really, really kind of accessible too. So if you live in a small town, a rural area, there's usually a major city that you could connect with someone via telehealth and have at least a consultation. And that would be something I would recommend if you're not quite sure.
Okay. Well, very good. Well, Kelly, so what areas do you serve? Is it all of California? Is it just San Diego? What can you do telemedicine across the U.S.?
Yeah, so I do telemedicine in California and Colorado, and then I do in person for anyone who can get to San Diego and into my office.
Okay, and very good. What's the best way for people to find out more about, your particular clinic? Where can they go?
Absolutely. My website is going to give you all of that great information, which is wellnesstherapysd.com. So wellness therapy, S like Sam, D like Diego.com. So wellnesstherapysd.com. And you'll have all of our contact information. Resources are available there as well. So if you're really struggling, you'd be able to connect with someone via numbers and links to crisis lines, things like that. But then, of course, our admin or our emails are available there too.
What about people who are not in your area? Where's a place they can start to find a practitioner and what would they be called?
Yeah, that's really great. So Google never hurt in that case, but another really, really wonderful place to look. There are 2 primary therapy directories. The biggest one is called psychologytoday.com, The other is therapyden.com. And you would go there and you'd be able to put in the symptoms you're experiencing, or if you do think it's psychosis or schizophrenia, you could put that in and look for people in your area. But there are also lots of other resources. So we have, and I am blanking on the number here, but you can call, I think it's like 411 and get some information. You can look at local hospitals or treatment centers. So in a place like San Diego, we have SHARP and UCSD health systems. So they have a lot of resources as well, outpatient and inpatient resources if you're feeling like there's something severe going on. But if you were to put therapist in my area, psychosis, or therapist in my area, schizophrenia, you're going to get a return from Google of a number of people who are looking for that. And then you would just make sure, either via phone or email, that they're trained in treating schizophrenia and psychosis before you move forward.
Okay, excellent. Well, Kelly, thank you so much for coming on the podcast. I appreciate it.
Thank you for having me.
Thank you for listening to the Good Question Podcast. Please email support@thegoodquestionpodcast.com if you have any referrals to great guests for us to interview. Visit thegoodquestionpodcast.com to hear more interviews. And please help us spread the word by rating and reviewing us on Apple Podcasts, iTunes, Spotify, YouTube, or wherever you listen to this podcast.